so much, Paula. That was really great information. And, questions, it looks like we've got 36 questions so far, and not that many have been answered. So let's get fast, although maybe they're listening to all these presentations, which we want them to do as well. So maybe during the break, they'll be answering more. Next, we're going to hear from our favorite West Coast neurologist. Well, I hope I don't get in trouble for saying that. One of our favorite West Coast neurologists, Dr. Chafic Karam from Oregon Health and Science. You're smiling, right? I'm in trouble. Okay. So Dr. Karam, why don't you take it away?
Thank you, Muriel. And thank you all for coming and listening to this talk today. I will be talking about the neurological aspects.
Can you turn up your voice a little bit, Dr. Karam? Maybe it's just me.
Is this better like this?
Quieter. Go ahead.
Is this better?
Yeah.
Is this better? Can you hear
me? Much better.
Okay, very good. Thank you. So disclosure, I have received payment from both Axia and Alnylam, and I get research grants from Axia. So for this talk today, we're going to start by an introduction to the nervous system. We will discuss then the impaired nervous system. We discuss the amyloidosis in humans. And then I'll focus a little bit more on TTR amyloid neuropathy treatment, because that's where we have most of the treatment at this time. And then if we still have time, discuss the management associated with amyloid neuropathy. So let's first start by the introduction to the nervous system. So this is a picture of the nervous system. You have the brain and the spine, and those we usually refer to as central nervous system. And then the other part of the nervous system is the peripheral nervous system. And this is all the nerve that once they leave out the spinal cord, and they also include the autonomic nervous system. This is a picture of a nerve. It has the axon, which is the kind of serpentine body of the nerve, and there is the body of the nerve. Now, if you pay attention to this picture, you see something in blue here, which is the myelin. The myelin is what wraps around the axon. Different disorders, different neuropathy affect either the myelin or the axon. It is important to recognize the difference, because if you have a disorder that mainly affects the myelin, the Schwann cell, which is the cell that makes the myelin, can actually regenerate and produce more of the myelin. So if you have an injury to the nerve, mainly to the myelin, there is a high likelihood that if treated early, the patient will recover. However, if there's damage to the axon, which is the inside of the nerve, the recovery is almost always incomplete and imperfect. In amyloidosis, the type of neuropathy is axonal neuropathy, meaning that the axons are damaged. And if that happens, it is very difficult for the nerve to grow back and to regenerate. And that is why it's very important when we assess patients with this disorder to make the diagnosis very early on, to be able to help the patient stop destruction of the axon and preserve the nerve. So if we treat patients who are very advanced with this condition, unfortunately, the recovery is very little. So if the patient has severe foot drop, severe weakness in their hands, even if we start treatment at that point, they may not recover much. We can stop the progression of the disease. That's the most we usually aim for. So what is the normal function of the nervous system? The peripheral nervous system is made of three parts. There's the sensory nerves, and these have also the sensory receptors. There are the motor nerves that goes to the muscle, and there are the autonomic nervous system, which I will show in a little bit. So the sensory nerve first starts by feeling. So in this picture, you see the patient or the man or woman is feeling the temperature of the water. And there's sensory receptors that take the message to the brain. And then the brain interpret the message and decide whether this is something pleasant or unpleasant, and determine whether a reaction is necessary by sending back a signal to the motor nerve and activating the muscle. This is a picture of the autonomic nervous system, which is automatic, meaning you don't think about it. And it controls most of your organs in the body. It controls your lacrimation, the tearing, the salivation, the heart rate, the blood pressure, your GI motility, meaning how the food moves in your in your guts, and other things that I'll show you in a little bit. It also controls the sweat, so control your body temperature, and so forth. This is a picture that shows you the baroreceptor. The baroreceptor is a system in the body that detects change in the blood pressure. So for instance, when you're laying down, you don't have a lot of gravity effect on your blood, and this way your brain gets the blood that it needs. However, when you stand up, gravity will pull the blood down, and you need to raise your cardiac output and increase your blood pressure to be able to maintain the blood going to your brain. So there is a reflex here that goes and sends signal to the nerve, to the blood vessels, and the blood vessel will constrict, and their heart rate, cardiac output will also increase. And in this way, the blood pressure won't drop and you won't feel lightheaded and even pass out. So this is totally automatic. You don't think about it. This is something that can be affected in amyloidosis. This is another function of the autonomic nervous system, is the food movement in the guts and digestion, and then going and having number 2. And you don't think about that. It just happens after you swallow. The food will move in the guts by the autonomic nervous system control. And this also can be affected in amyloidosis. So let's talk now about the impaired function of the nervous system. One of the most frequent signs of amyloidosis is peripheral neuropathy. And that happens because you have amyloid accumulation in the nerve that can interfere with the proper function of the nerve. It can also cause destruction of the nerve. It can cause ischemia, meaning reduced blood flow to the nerve, and causes neuropathy. Typically, the neuropathy in amyloidosis is length dependent, meaning the very distal aspect of the limb are affected first. For example, people a lot of times start having symptoms in their toes. And as the neuropathy spread, it goes up to the ankle and the mid-shin, and then the hand starts being affected as well. It is also symmetric, meaning that both sides are affected at the same severity. It affects both the sensation and the motor nerve. Usually it starts with the sensation, and as the disease progresses, the motor nerve start getting affected and the patient start feeling weak. And of course, it is progressive, and we'll get to that later. The symptoms of neuropathy can be sensory, motor, or both. For some reason in the ATTR amyloidosis, if people start at a young age, they have a lot of sensory symptoms: numbness, pain, tingling, burning sensation, very annoying zinging in the toes, and very uncomfortable. Even sometimes light touch can cause severe pain, and eventually, as more nerve becomes impaired, they start having balance difficulties. However, in older patient, pain may not be the main symptom, and they may have more weakness. They can trip on their toes or on the feet. They have difficulty standing on their tiptoes. The hand grip becomes difficult. They have difficulty opening the doors, doorknob, turning the keys, etc. So how we diagnose neuropathy, this is important. The symptoms that I just showed you of peripheral neuropathy are non-specific. any types of neuropathy can give you similar symptoms. People who have severe diabetes or uncontrolled diabetes develop neuropathy, and the symptoms can be exactly the same. People who drink a lot of alcohol can develop neuropathy with exactly the same symptoms. People who have vitamin deficiency or who have been exposed to toxic agent. So that is one of the challenges in amyloidosis, is that the symptoms of the neuropathy are not specific for amyloidosis, and any type of injury to the nerve will give you very similar symptoms. And to diagnose neuropathy, we usually rely on several things. We rely on what the patient is experiencing, and these can be the symptoms could be really caused by neuropathy or could be caused by problem in the back or in the spine. So a careful neurological examination should be followed, and we should be able to determine whether the problem is coming from the nerves or not. And then, of course, you have the findings on laboratory testing. There are several laboratory testing that we can do. One of the testing that we do most commonly is a nerve conduction study, where we stimulate the nerve at one site and record at another. It's not a very comfortable study, but it is very important to detect the type of the neuropathy and the severity of the neuropathy. In some occasions, we also do skin and nerve biopsies, and we do quantitative sensory testing. The skin and nerve biopsy are not only for diagnosis of the neuropathy, but sometimes can help us determine why the patient has neuropathy, such as in amyloidosis. Symptoms of dysautonomia or autonomic dysfunction are erectile dysfunction in men. This is one of the more frequent signs that the patient experience. They may not always complain about that, and if they're in their 60s or 70s, they may assume that that's just part of normal aging. Another thing is constipation. So the autonomic nervous system controls the bowel movement, and if it's not working, it's going to cause constipation. Sometimes when the constipation becomes very severe, it is followed by diarrhea, so people may experience alternating diarrhea and constipation. Sometimes they just experience diarrhea on its own, and it can be hard to determine whether it's due to the amyloid in the guts or the amyloid in the autonomic nerve. Incontinence, soiling, very uncomfortable, very embarrassing. And sometimes people can no longer come and see us in the clinic because of these problems. Early satiety, meaning the patient feels full early. They take 1 or 2 bites and then they feel full, and that results in loss of weight, nausea, regurgitation of indigested food because the food is not moving from the stomach down the duodenum and intestine and colon. Orthostatic hypotension, and I'll talk a little bit more in details in the next slide, and heat intolerance. Remember, the autonomic system controls your body temperature. If it's very hot, you need to sweat. And if you're not sweating correctly, then you will feel very uncomfortable because your body temperature will rise, and you may feel very sick when it's warm. Symptoms of orthostatic hypotension, these can be sometimes very clear. People stand up and feel lightheaded and faint. That is a good indication that their blood pressure is probably dropping when they're standing up. But sometimes there are some symptoms that are difficult to say for sure this is orthostatic hypotension, such as confusion. The patient gets confused when they stand up. The vision gets dimming. They get a pain in their neck and shoulder when they stand up as well. Sometimes they may have shortness of breath and chest pain as a result of the drop in the blood pressure when standing up. So how do we diagnose dysautonomia? Again, the symptoms that the patient may volunteer, but also with a careful review of system, and we ask specific targeted question to determine whether there's dysautonomia or not. The other thing that we have to make sure is that the patient is not taking medication that can cause side effects that look exactly like dysautonomia. So for example, patients who are taking medication that cause constipation, we need to look at that and maybe remove those prior to diagnosing dysautonomia. Some medication also cause drop in the blood pressure, and it's important to also look at those and review the medication and adjust them before we diagnose dysautonomia. Certain clinics have something called Autonomic reflex screen, which is a battery of testing where we look at how the patient is sweating, how the blood pressure is changing, either with Valsalva maneuver, meaning when they push hard, or in the tilt table, meaning we put them on a tilt table and put the table up and see how the blood pressure is changing with that, as well as how the heart rate is changing with both of these procedures and with deep breathing. If these type of testing are not available in the clinic, it's not a big deal. The doctor or the nurse or the medical assistant can take the blood pressure of the patient after they lay down for a few minutes. Then when they stand up at 1 minute, 3 minutes, and 5 minutes, and see how the blood pressure is changing and how the heart rate is changing. If the systolic blood pressure drops more than 20 points, or 20 millimeter of mercury, that means that the patient has orthostatic hypotension. Another thing that I'd like to talk about, carpal tunnel syndrome, it's a type of mononeuropathy. So it's different from the polyneuropathy that I was just mentioning before. It is caused by a compression of the median nerve, which is the nerve that goes to your fingers in the hand. And usually it's an external compression, okay? In amyloidosis, different type of amyloidosis, including AL or wild type or ATTR, you would have amyloid being deposited in this transverse carpal ligament, and that will cause compression of the median nerve and loss of oxygen, and you will have symptoms in your fingers. You will have numbness, tingling in the hand, and mainly in the first 3 digits. In the beginning, it will wake you up at night and you have to shake your hands. And then as you're holding the phone or the newspapers or typing on the computer, you may be experiencing more and more. And as the disease progresses, the symptoms become persistent and you'll notice shrinking of the muscle and weakness in the hand. Now, this is an important sign of potential amyloidosis. About 50% of patients with amyloidosis will have this carpal tunnel syndrome sometimes a year before they are diagnosed with their condition. The problem with this is that it is also very common in the general population. About 5 to 10% of the general population gets carpal tunnel syndrome without having amyloidosis. So it's very important to look at this and take it in context. Now let's move to amyloidosis disorder in humans. Usually the amyloidosis is caused by proteins in the blood that have specific function. So, and we'll talk about this in a little bit. For example, the TTR has a function of transporting vitamin A, thyroxine, and so forth. So different proteins are normal in the body, they occur normally, but for some reason, either it's because of genetic problem or because of an acquired problem, they start misfolding and depositing in organ, causing damage. And these are different disorders. So they have different treatment. So what works on one may not necessarily work on another. And actually some of them are very different. So AL, light chain amyloidosis, is a type of plasma cell dyscrasia. It's treated with chemotherapy or stem cell transplant, whereas transthyretin is more treated with gene interfering drugs. So the one that we have inherited are the transthyretin, that's the most common, and we're gonna refer to that as HATTR. It also can be acquired with the wild type TTR, and you just heard about this from the cardiologist, or it could be iatrogenic, meaning that a patient received liver transplant that has the mutation and then eventually go on to develop the disorder. Another inherited one is the apolipoprotein A1, gelzalin, and the fibrinogen, and the acquired ALEC2 is also one of the ones we see in the US. So let's first start with the gelzalin or A-gel. This gelazolin protein is produced mainly by the muscles, and a mutation in the GSN gene causes the disease. Most of these patients have Finnish ancestry, and most of the cases are actually found in Finland. And the patients in their 20s start having a problem with their eyes. They have a specific type of corneal dystrophy called late lattice corneal dystrophy. And the deposition of the amyloid in the cornea is very suggestive of this condition. And then in their 30s and 40s, they might start having problem with their facial muscles. They have difficulty moving their facial muscles, and they can get to the point where they have paralysis of their muscle. Although the penetrance of this condition is 100%, meaning almost everybody who have the mutation will develop the disease, the presentation is very variable and the disease severity is very variable. The other thing about this condition is that the skin is loose and sometimes can be easily stretched. Some patients develop sensory neuropathy, the symptoms that I just discussed about numbness, tingling, burning pain in the hands and feet. Some description of this disorder affect the tongue and the swallowing muscle, and these patients may have been misdiagnosed with motor neuron disease or ALS. Some patients can have cardiac conduction defect, cardiomyopathy, dysautonomia, GI disturbance, and kidney involvement. The good thing about this disorder is that people have normal lifespan. So if you compare these patients to the general population, they survive as long as the general population and don't have reduced lifespan. There's no specific treatment, unfortunately, for this condition. Doxycycline could be used because it's non-specifically disrupt amyloid fibrils. And then all the other treatment are symptomatic. So if the vision is impaired, one can have corneal transplantation. If the facial disfiguration is bothersome, you can have plastic surgery. If the eyes are dry and the mouth is dry, you can have eye drops, oral care. And whether the heart and kidney are involved, then the management would be as needed. Let's move on to the apolipoprotein A1. This is another rare hereditary type of amyloidosis. This protein is made by the liver and intestine, and it's the main component of HDL, which transport your kind of good cholesterol. They've seen both hereditary and wild-type amyloidosis, so they describe two kinds, same as TTR. And this condition, it depends on the mutation and the patients, but a lot of patients develop amyloid in the skin, so it's visible. And they develop also hoarseness in the voice, so you can kind of run in the family. They have like a smoker voice, but they actually never smoked. So people can tell in their family when the disease has started. And some of these patients may have neuropathy. The neuropathy is also mild in this condition. The major complication is, of course, the kidney problem. It causes tuberointerstitial nephritis, and this can lead to significant problems. But in this condition, some studies suggested that organ transplant, liver transplant, and kidney transplant may be helpful. So now let's move on to the ATTR, which the majority of you listening today have this condition or know somebody who have this condition, because it's the most common. And it comes in two flavors. There's the wild type and there's the hereditary. And we will refer to the hereditary ATTR with HATTR. People who have this condition have mutation in the gene. And the other one is the wild type, meaning that there's no mutation in the gene. And the presentation can be different. So this is the TTR protein, and you saw a picture of this prior in the cardiology presentation. And what happens with this protein, and as I mentioned, it has a proper function. So It transports vitamin A, it transports thyroxine. So it's useful type of protein, and it's made mainly by the liver, but it's also made in the brain and in the eye, and some in very small quantity in other organs. So normally the protein is formed by a tetramer, meaning these 4 parts of the protein, and they usually attach to each other and they work nicely. However, if there's a problem in this protein, it becomes dissociate, misfold, and then deposit and give you this kind of amyloid that is pretty destructive to organs. And depending on where it is depositing the most, the patient is going to present first with this symptom. So if it's depositing mainly in the nerve, they're going to come with neuropathy. If it's depositing mainly in the heart, they're going to come with heart symptoms, and so forth. So when we looked at our patient population here in OHSU, where I currently work, patient, about half of them actually had carpal tunnel syndrome prior as a first manifestation, and about a quarter had dysautonomia or GI issues, and then 14% had cardiac problem, and 14% had neuropathy. So eventually, we all diagnose these patients because of the neuropathy or because of the cardiomyopathy, but the disease has started actually in some cases many years earlier. Now, because carpal tunnel syndrome is common among the general population, this was not very helpful. But when we look more closely on the data, over 60% of patients with carpal tunnel syndrome also had other symptoms at the time of carpal tunnel syndrome surgery. So 20% had also neuropathy, 20% had cardiomyopathy, and another 10% had dysautonomia or GI dysfunction. So basically, when you have carpal tunnel syndrome, we ask our doctors and our fellows to screen for cardiac involvement, neuropathy involvement, GI involvement, or dysautonomia, because this could lead to the correct diagnosis. Now, that being said, still a significant number, about 40%, only had carpal tunnel syndrome and didn't have any other sign that suggests that they may have amyloidosis. So again, the diagnosis remain a little bit difficult. You saw this picture before. ATTR amyloidosis is a systemic disorder. The amyloid protein can deposit anywhere in the body, but most of the patients present either with neuropathy, cardiomyopathy, GI dysfunction, or dysautonomia. But as the disease progresses, they can start having brain involvement, hearing involvement. There are certain mutations where it's really mainly central nervous system that is involved. People present with dizziness or imbalance and hearing loss, for example. So what are the challenges in hATTR? Why are patients diagnosed very late on? And we get this a lot. And actually, I think one of you asked the question here. This is a very rare disorder. So in general, as our cardiologist said, usually we think about the common disorder first, because usually you're right. If the 95% of neuropathy that you see in your practice is caused by diabetes, that's what you're going to think about. And most of the time, you're going to be correct. It's those rare times where there's an alternative diagnosis. We looked at patients that were referred to us, and about 2/3 got an incorrect diagnosis when they were first seen. And there are different diagnoses that were given, peripheral neuropathy from diabetes, alcoholism, idiopathic peripheral neuropathy, just plain carpal tunnel syndrome, fibromyalgia, irritable bowel disease, and so forth, CIDP, and being treated for CIDP. So there's different type of misdiagnosis, and patient may go for many years with wrong diagnosis and treatment for condition that they do not have. However, there are distinctive features for the neuropathy in hATTR. So the autonomic dysfunction, the GI dysfunction, the blood pressure drop when people stand up, these are usually rare in other type of neuropathy. So if you have those, then that is highly suggestive that maybe we're dealing with amyloidosis. The other thing is the rapid progression of the neuropathy. Usually in idiopathic neuropathy or diabetic neuropathy, especially if the disease is well controlled, the neuropathy progresses extremely slowly. You know, it takes years and years to see any change in the severity of the neuropathy. Pain itself may fluctuate, and pain itself is not a good reflection on whether the neuropathy is getting worse. We do look at the function, if the patient is losing function or not. The pain can, you know, improve with progressive neuropathy, or can actually worsen with improvement of the neuropathy. So it's not really a good indicator if things are getting worse. And then, of course, you have the specific cardiac features that can be very helpful, suggestive of an infiltrating cardiomyopathy. And then another thing is that if people have recurrent carpal tunnel syndrome, or the carpal tunnel syndrome does not improve after the surgery, that should be a red flag that maybe they have a different condition. So this is a study that I'm doing with the help of Axia. We looked at patients in our clinic with different types of neuropathy: Charcot-Marie-Tooth, which is an inherited neuropathy, diabetic neuropathy, and idiopathic neuropathy, and hATTR neuropathy. And hATTR neuropathy is in the bottom right corner, and you can see people, everything that goes up here is bad, and the neuropathy is progressing at a much faster pace when compared to these other type of conditions. So that should be a sign that the neuropathy is getting much worse. And it should be a sign that the patient may have amyloidosis. This is another study that we're also doing with the help of Axia, is looking at very early signs of neuropathy. So as I mentioned before, if you have patient with severe axonal neuropathy, they're not going to recover that much. We want to find patient very early on. So we've been doing this study, and I thank my patients, and some of them have traveled from all over the States, as far from Boston, to participate in this so we can get more data. And as you can see here on the left side, you have these Meissner corpuscle that are sensory endings, and this is the normal control. And when you look at the right picture, this is a patient with amyloid neuropathy, and you see these Meissner corpuscle are completely absent. So we're going to talk about the current treatment for hATTR neuropathy. You've heard about those earlier, but you're just going to hear my perspective. So the treatment focus on specific treatment for TTR, but also on the symptoms. So as you remember, and I just mentioned this earlier, the TTR is made primarily by the liver. Again, it's made by other organs, but most of it comes from the liver. And liver transplantation was started in the 90s, was the first available treatment. So the liver is producing this protein that is not doing a good job. So the idea was we remove the liver and we put a different liver that doesn't have the mutation in the gene, and it should work. And we'll get to that in a little bit. It does work in certain cases. Another way, and this is what happened recently, is that we tell the liver to, hey, stop making this protein. So we suppress the production of the protein by interfering with the RNA. Now, once the protein is secreted, you can also stabilize it. We have medication for that. And once the amyloid is deposited, then you can also remove or destroy these amyloid fibrils. The latter is a little bit under investigation right now. So doxycycline is something that we have, and people can take it. But the study that we're looking at is the PRX with the antibody that goes and attacks these fibrils to remove them from the body. So liver transplant, it works really well in certain conditions, especially young people with V30M mutation. However, people who have different type of mutation, it may not work that well, and people may continue to progress. So we have patients who've had liver transplant, but unfortunately continue to progress. The challenges with the liver transplant is that, of course, you have to wait for a donor to be available, and there's a wait list. It involves a big surgery. You need a specialized center, and you're going to have to take medication to prevent the the organ rejection. Like any surgery and any medication, you will need to approve the risks that comes with the surgery, and during surgery and following the surgery. The two new treatments that were available in the last couple of years are inotersen and patisiran, and these drugs interfere with the production of the TTR protein. So some of you may know the DNA is read into an RNA, and then the RNA is translated into a protein. And these drugs interfere with the RNA itself, and this way you have a dramatic reduction in the production of the TTR protein. The two drugs that were mentioned before are inotersen, patisiran. Inotersen is a subcutaneous injection. So after a loading dose of 3 times the first week, you just go on and do once a week. You do not have to pre-medicate with this medication, but you have to be careful and monitor the platelet every week to make sure there's no risk of thrombocytopenia. Some patient, a small minority, did experience drop in the platelet, which can lead to bleeding. So you have to prevent this by monitoring very carefully the platelets. You also have to monitor the urine every 2 weeks and the liver function test every 3 months. Patisiran is a different drug, and it's called Onpattro, where inotersen is called Tegsedi in the US. Patisiran is injected every 3 weeks. You do need to pre-medicate with steroids, antihistamine and antiacid an hour before the infusion, and then you infuse it over approximately 80 minutes. With this drug, you don't have to monitor the platelet or the kidney. You could have sometimes infusion-related reaction, and usually adjusting the medication can help. This is a picture that shows you on the left side the suppression of the TTR production. So the lines in black and the round circles are people who are on placebo, and you can see the TTR doesn't change level, whereas in the people who are on inotersen, in the blue line, you see a dramatic drop in the production of the TTR protein. And this is reflected by improvement in the neuropathy and reduction in the progression of the neuropathy as reflected by the neuropathy impairment score, as well as the quality of life in people who were on inotersen was stable, whereas people who were on placebo had worsening in their quality of life. Same thing with patisiran here. You can see the dramatic drop in the TTR level up to 80%. And then you can also see the effect on the neuropathy, improvement in the neuropathy, and the quality of life. The next drugs are the drugs that works on stabilizing the TTR. So diflunisal, which is a non-steroidal anti-inflammatory drug, and tafamidis, which works in a similar fashion, attached to the TTR protein and makes it stable. So this way you have less dissociation and misfolding and amyloid deposition. So this is after the TTR has already left the liver and it's in the blood that these drugs are working on it. And these drugs work as well. Diflunisal, if you look at the neuropathy impairment score here compared to patients who are on placebo, there was a significant change or difference in the neuropathy impairment in the patient who were on diflunisal. They did much better than the people who were on placebo. We have kind of similar, a little bit actually weaker data with tafamidis on the neuropathy. And because of that, when they applied for FDA approval in 2011, it was not approved in the US. It was though approved in Europe, and it's been used for many years there for stage 1 and sometimes stage 2 FAP or familial amyloid polyneuropathy. However, tafamidis is approved for cardiomyopathy, TTR cardiomyopathy in the US based on this study. As our cardiologist mentioned, that the effect as you can see, people, unfortunately, all people continue to progress. However, at 18 months, you see that the people who are on tafamidis have progressed actually at a slower pace than people who were on placebo. And that showed that there's a reduction, I think about 30% in hospitalization and mortality in people who were taking tafamidis. So, you know, the difference, I think, in the other drugs, we see response at 9 months for the neuropathy. Maybe they are slightly superior. We just don't know because we didn't compare them. But based on the studies for the neuropathy in the US, we prescribed the knockdown therapy. The other thing with this study on tafamidis is that it worked on, it included both wild type and ATTR, and the majority of patients were wild type. So it's a little bit difficult for us neurologists to know with the hereditary how much that would help as well. So that being said, we move to symptomatic treatment. Symptomatic treatment, these are not specific for TTR. These are things that we use for any type of neuropathy, whether it's related to amyloidosis, diabetes, CMT, and so forth. So the pain, there are many different medications that we use for pain. None of them are specific for neuropathy. The one that I usually try to start with are gabapentin and duloxetine because they have less of, side effects and good efficacy for the neuropathy. For diarrhea, loperamide, opium tincture works very well. For the nausea and vomiting, we use ondansetron and dronabinol. Orthostatic hypotension, midodrine. You know, we can also use other things like droxidopa, fludrocortisone. And for the constipation, Miralax, which has a lot of fibers, selnacolase, among others. So in conclusion, different forms of amyloidosis have variable neurological involvement. The treatment is also different for this condition. So you cannot use the same treatment that you use for TTR, for example, and for AL. They're not the same condition. Even in the same protein mutation, the presentation may be highly variable. Even in the same family, penetrance and age of onset, disease progression are also different. And we're very happy that now we have an increased number of therapeutic options for TTR amyloidosis. There's still actually several clinical trials going on for novel type of modification of the therapies. And I suspect that we're going to continue to have more and more success with these conditions. So thank you very much, and I'm happy to answer questions later in the Q&A, and I'm also trying as much as possible to answer by typing the answer to the question that you're asking here.